support by พวกเราเข้าใจคุณ
Hello, welcome to this first episode of the Yanhee Pride podcast. My name is Don, broadcasting here from Yanhee International Hospital in Bangkok, Thailand. This podcast is intended to be a series to explore the seemingly complex world of gender affirmation surgery. Today, Thailand is considered to be the undisputed sex change capital of the world. It has earned this reputation through decades of pioneering surgical techniques, unparalleled expertise, and a compassionate and understanding culture. Here at Yanhee, we take immense pride in being one of the few centers in this country to offer a full spectrum of gender affirmation surgeries, from male to female to male procedures, all under one roof. In this first episode, we will discuss this new technique for the male to female gender affirmation surgery, the full-length peritoneal flap vaginoplasty. This groundbreaking surgical innovation offers a self-lubricating, hairless, and deep vaginal canal. And as the term suggests, this technique does not utilize penile or scrotal skin, neither the colon or the large intestine, but this stretchable, delicate piece of human tissue called the peritoneum. Today, it is my greatest honor to welcome a leading gender-affirming surgeon in the MTF community and the innovator of the latest advancement in the MTF surgery, the full-length peritoneal flap vaginoplasty, in the person of Dr. Worapon Ratanalert. Welcome to this podcast, Dr. Worapon.
Good afternoon, Doctor. I have very honored to be here today.
Doctor, before we proceed with our topic for this first episode of this podcast, I would like to request you to give details about your educational and medical background, as well as your training and your work experience.
Okay, sure, Doctor. I finished the Doctor of Medicine from Chulalongkorn University in 2011. And after that, I go back home to studying general surgery. So I finished board of general surgery in 2016. After that, I came back to Bangkok to studying the plastic surgery training in Chulalongkorn University and finished that training in 2019. And after I finished all of my educations, I was working in Chulalongkorn University and one of the transgender specializing clinic.
I see.
So for practicing my vaginoplasty surgery with my senior staff at Chulalongkorn University.
It means to say, Doctor, that your training was the best training you can get in Thailand.
Oh yeah, Doctor. Actually, the vaginoplasty procedure can be trained in every plastic surgery training center, but actually, Chulalongkorn University they are a pioneer of starting this procedure in Thailand. So they have many cases per year. So I would say it is the best to train the vaginoplasty in Chulalongkorn University.
Okay. So, Doctor, in the June 20, 2025 issue of the journal Plastic and Reconstructive Surgery is an article entitled Full-Length Peritoneal Flap Vaginoplasty, a feasible approach for hairless neovaginal reconstruction in gender-affirming surgery, the author of which is listed as Dr. Worapon Ratanalert. Could you confirm that this is you being cited as the author of this?
Yes, sure, Doctor. I and my partner, Dr. P. Popan, we developed the technique and wrote this article.
So, Dr. P. Pobman is not only a co-author of this article, but he is also your partner in doing the surgery itself.
Yes, doctor. To do the full-length peritoneal flap vaginoplasty, we have to work together, have a like team surgery.
So in the procedure itself, there are two teams.
Two teams, yeah.
You approach from the vaginal side,
Yes, yes.
while Dr. Pobban and his team approach from the peritoneal side.
Yes, doctor. That's correct.
Now, before we go into the details of this innovation, I would like to go back to the other options so that we can compare the advantages and disadvantages of the other options of the surgery. First, of course, is the
Skin grafting or penile inversion vaginoplasty. I would say that in the categories of the skin-based lining, it is the standard technique worldwide. It is good technique actually, but the problem is some people who have very hairy in the genital area, they will have the hair grow inside their vaginal canal. And some people who are taking hormone for a long time, their skin, the genital skin getting very smaller. Or even some people who have orchidectomy, the skin very small, so they don't have enough skin to line the vagina.
Of course, doctor, the second option is
The colon vaginoplasty. It is a quite well-established technique and quite standard in a patient who don't have enough skin. But the disadvantages of the technique is to have the abdominal surgery to harvest the intestine. That be considered as a semi-sterile technique because we have to open the intestine, take apart a segment of the intestine to be a vaginal lining, and then connect the remaining part together. The other problem of the colon vaginoplasty or other intestinal vaginoplasty is it can have the colon disease in the vaginal canal, such as inflammation, polyps, or even colon cancer.
I see.
So we have to surveillance for that disease. And the invasiveness of the surgeries make patients after surgery need to be like stop eating food and then step diet. So the postoperative cost would be more like difficult for the patient.
So the third option, doctor, is
I will say that the third option is the peritoneal vaginoplasty. You may know the word PPV. The PPV is the popular word known in among patients. It stands for penile-peritoneal vaginoplasty because actually this technique is a hybrid technique because they use the penile inversion skin at first half of the neovaginal canal, and the second part is the peritoneal pull-through.
I see.
So I would say that I used to do this technique before, but from my experience, patients who are choosing the peritoneal vaginoplasty, they want the property of the peritoneum that should be mucosal lining, totally hairless, and producing some of the lubrication
Lubrication. See.
entire of that near vaginal canal. It
see.
doesn't want a hybrid technique. So I would try developing some of the new technique to produce the total peritoneal vaginoplasty.
Which leads us to the fourth option, which is the full-length peritoneal flap vaginoplasty.
Doctor, I can say that.
I see. So the PPV, what used to be used, the PPV, is the precursor.
Yeah,
It was the beginning of the idea.
Yes, this is the beginning technique of the peritoneal vaginoplasty.
I see. So now, doctor, this full-length peritoneal flap vaginoplasty was originated here at Yanhee by you and Dr. P. Pobban.
Yes, doctor. I and Dr. P. Popan, we developed the technique. He actually is a urologist, but based in the Chulalongkorn University, and he's my friend, old friend. So we met in a restaurant, and we are talking about the surgeries. And I knew that he very familiar with the peritoneal harvest and dissection because he has to do the surgery of the prostate gland. So we are talking and developing how to making a flap from the peritoneum to be um, big enough to line the total length of the neovaginal canal, and also it has to contain a blood supply, so it doesn't it isn't a graft, so it will survive.
The
So
peritoneum will not die.
not die. If it die, it will like disappear, and
And no more lining.
no lining or the scar can be
Replaced by a
yeah.
scar. So, doctor, this because this is a new innovation, you have to have the technique of harvesting the peritoneum, which is, I think, the most critical.
Yeah, the most difficult part of the technique is the how to design the flap, how to place the flap position in the abdominal wall, how to place the proper blood supply to entrance the peritoneum. And the most challenging part is the most challenging part is the how to determine the proper flap size, because each patient very different in the body size, and the neovaginal canal size is different. So we try to like tailor this detail by patient to patient and follow up the result. And now we get the proper size for each patient, but they need to customize. Like you make a garment for a person, they have to be customized for each person to each person.
So, what you are saying, doctor, is that when you do the harvesting of the peritoneum, you really custom make the size as well as the length so that it will fit the correct anatomy, the anatomy of each patient.
Yeah, I would say that if we not provide enough lining, the peritoneal lining to the neovaginal canal, it will like make the procedure fail. Eventually, total vaginal canal close or developing into like granulation wound. If we let the wound heal by itself, the peritoneum disappear. So it is very critical to determine the proper size of the peritoneum to each patient. Another difficult part is the transferring the flap. We need to transfer the peritoneal flap without any tension, because the problem of the pull-through technique is the somewhat inadequate dissection. Make the pull-through, they have tension in the peritoneal edge that can pull back the peritoneum in the original position. It will result in the closed canal.
So, doctor, in the animation that you have shown, the peritoneum is harvested in the anterior abdominal wall.
Yeah, we choose the anterior abdominal wall because it is like safer for us, because Dr. P. Popan, he is a urologist, so he is very familiar with the anterior part of the abdominal wall, as well as the urethus, as well as the urinary bladder. So we don't want to go close to the rectum, because if we injury to the rectum, it is more difficult to us to like to repair.
Yeah, it's going to be catastrophic if you penetrate the rectum.
Yeah, very difficult, and maybe end up with the colostomy somewhere.
So, doctor, again, I want to go back to the animation that shows that you mobilize the peritoneum and anterior abdominal wall superiorly and laterally and bring it down to make it into a tube.
Yes, doctor. The peritoneum is in the original in the square shape.
I see.
And detached from the abdominal wall, keeping the main blood vessel from the urethus, the urethral branch vessel. So we also have confirmed that the flap is vascularized by using an ICG angiography, which maybe I would publish it later. And then we will call the manner of the flap transfer, that is the turnover. Turnover, yeah. So that we have to make a flap size enough after turnover that is will be no tension.
No tension.
no tension at all, and can reach the vaginal introitus
Introitus.
without tension.
So that is why you call it full length,
The full length.
because the entire neovaginal canal is now covered by peritoneum.
Yes, doctor. Because most patients choosing the peritoneal vaginoplasty, they want to have the property of the peritoneum entire that neovaginal canal.
So can you enumerate the advantages of the peritoneum being the lining?
First is very similar to cis woman vagina.
I see.
Um,
It is covered by cells, right?
yeah.
So the lining is similar.
Yeah, very similar. So there is a technique called Davidoff procedure.
Uh-huh.
In a cis woman with vaginal agenesis. So they use the peritoneum pull through. But in male to female transgender patient, they need more peritoneum than cis women. So we need to design a new technique that can provide enough peritoneum to line the neovaginal canal.
So histologically speaking, the
Yes.
peritoneum is almost the same as the cis
Yeah,
vagina.
almost identical.
Okay. But the second, doctor,
And the second, there are many patients who have a very difficulty with the hair inside the vagina. So having hair inside vagina can make the hygiene not good enough, make a vagina bad smell. So the peritoneum is no hair.
hairless.
Hairless, and totally no producing of a sebum. So there is no bad smell inside the
So
canal.
hygienic is better hygienically.
Hygiene is much better than the skin or even colon vaginoplasty.
And then it produces its own lubrication.
Yeah, it will produce some of the lubrication fluid from itself that can
Because we know that the peritoneum produces peritoneal fluid.
Yes, doctor.
And when it is transferred to line the new vaginal canal, it will function in the same manner.
Yes, doctor.
I see.
And in patient with the very small skin and not enough to choose with the skin-based technique, they have to choose with the colon vaginoplasty or other options. So comparing colon vaginoplasty and peritoneal vaginoplasty, it is less invasive than colon vaginoplasty.
Less invasive.
Less invasive.
And then how about the stretchability? So it's a piece of tissue that can be stretched.
The critical point is providing the enough peritoneum amount into the canal. It is quite like difficult for the beginner. It is not straightforward to think the canal in like tubular structure. We have to provide more. Provide more to make it stretchable and make the entire lining no tension in every direction.
I see. So, doctor, to make it clear, the innovation that you have made is really on the lining, on the choice of the lining.
Yes, it's a choice.
In the making of the new vaginal canal, in the dissection, it's the same, whatever the covering may be.
Yeah, same. And also the vulva reconstruction outside, the external appearance, it depends on the surgeon preference. This is only the lining.
The lining.
Yeah.
And then in your article, you mentioned about you tested the bladder function.
Yeah, we also test the bladder function because the flap is rely on the bladder dome.
Okay.
Yeah, so we have the questionnaire to the patient to assess the bladder functions after surgeries. And almost every patient have no problem with the urination after surgery. So we can confirm that this is the safe technique to perform without any like disturb of the bladder.
I see. So you just wanted to make sure that the procedure of harvesting peritoneum in the dome of the bladder will not affect the urinary function of the individual.
Yes, doctor, we have to make sure that.
I see.
And also the peritoneum that we harvested, we also have an evidence that it can regenerate it by over time. We have a case that have the second surgery not related to the vaginoplasty.
I see.
And she has the surgery in Yanhee, and we have a chance to go inside the operating room to see how is the peritoneum is going, and we see that it is totally regenerated,
I see.
the new peritoneum.
So what you're saying is that since the peritoneum is harvested and there is going to be a raw area that is left behind, that you are confident
Yeah.
that the regenerative function of the peritoneum will be such that it will be covered by itself.
Yeah. Because some of the medical person we may think about the adhesion.
Additions.
Yeah, we also do the anti-adhesive gel
I see.
putting inside the raw surface after peritoneal harvest.
Before the closure of the
before
adrenal.
closure. Yeah, and we see from the case that the adhesion is very minimal,
I
and
see.
the peritoneum can be regenerated.
So, doctor, you have brought with you a model. Can you demonstrate to us, using the model, how you mobilize the peritoneum and
Yeah,
bring
sure.
it down, and then it becomes the lining of the neovaginal canal?
Sure, doctor. Okay, this is the model of the vagina. I have to want to show that how the peritoneal flap vaginoplasty is done. This is the neovaginal space that dissection with during surgery. So we would like the peritoneum to line from the apex. This is the abdominal cavity into the introitus.
Introitus. Okay.
Introitus. So comparing with the pull-through technique, the pull-through will make a peritoneal puncture here and make a circular dissection around
The cul-de-sac.
and then pull. So from my experience, the pull-through usually result in some of the tension. The peritoneum may spring back if dissection is not adequate enough. So, and the pull-through technique is very difficult to line the entire vagina.
Because
So-
because of tension.
Yeah, tension. So what we do is the making a peritoneal flap. Actually, originally in square shape,
Square.
and we suture it into a tube like this, and then we suture to close one end.
The superior end.
Yeah, at first it was inferior, but finally it will be
It's
superior.
because superior.
Yeah.
When you pull it down.
Yeah, we will
Okay.
turn over.
Turnover.
And the peritoneum attached here, and this is the point where it blood supply come in. So we make a cul-de-sac puncture and then turn over the peritoneum inside the canal. So the critical part is to make the flap size big enough to be transferred without any tension.
Tension.
If we do not reach the introitus, it will fail,
Fail.
or need to have the hybrid technique in same procedure. But okay, we have done many cases, and we know how to making a proper flap size to reach the introitus.
Enough size.
Yeah, without tension.
Without tension. Okay.
Yeah, doctor, this is how
That's the way.
full-length peritoneal vaginoplasty that is done.
Okay. In this debut episode of the Yanhee Pride podcast, we've had the distinct honor of speaking with Dr. Worapon about his remarkable innovation, the full-length peritoneal flap vaginoplasty. As we've learned, this technique is a significant advancement in gender-affirming surgery, particularly in the male-to-female iteration, focusing specifically on creating a superior vaginal lining. What makes this method truly unique is that the peritoneal flap provides a naturally hairless, highly stretchable, and self-lubricating surface, making it, as Dr. Worapon explained, a superior option to the alternatives available today. It is important to remember that this groundbreaking technique is for now only performed by Dr. Worapon himself, exclusively here at Yanhee International Hospital. We are truly grateful to Dr. Worapon for sharing his expertise and shedding light on this innovative procedure that is pushing the boundaries of surgical care. Please do stand by for future episodes of this podcast. I'm Don, your host, now signing off.